I'm a clinical researcher at UCLA Integrated Substance Abuse Program. So what I'm going to be talking to you today about, broadly speaking, is psychosocial intervention for stimulant-dependent adults. I'd like to acknowledge my collaborators for data that I'll be showing you on one of the newer interventions that we've had in our clinical research. And to give you an overview, the newest data that we have that I'm going to present towards the end of the talk is on mindfulness-based relapse prevention. And we're very excited about what we're seeing in terms of efficacy of that intervention for some of our clinical targets and outcomes for stimulant users. But I also just wanted to give you kind of a broad overview of the different types of behavioral interventions that we use with stimulant-using populations. And largely because I'm in the fortunate position that I both do clinical research on these interventions, but also as a clinical psychologist, I've actually delivered many of the interventions. So I thought it might be nice for you to have a sense of actually when you have a drug user in a room and you're doing cognitive behavioral therapy or you're doing contingency management, what exactly is that and what are you trying to teach the substance user to do differently in their life that you hope will extend beyond the impact treatment. We've heard a lot sort of conceptually and Dr. Grella talked about sort of like the patterns that we see longitudinally in substance users who have been in and out of treatment. But this is going to be more of a talk about what treatment really means in the sense of treatments that are most frequently used in the drug addiction area. So I'm going to start with cognitive behavioral therapy and relapse prevention. Generally, the principles of CBT, CBT is a very much teaching-based approach in which we want to not only encourage and support reductions and cessation in substance use, but we really want to educate people about their condition so that they really understand it in a very intimate way and become sort of what I would call like the self-expert on their own patterns of drug use in terms of in what situations and what context substance use occurs, where and when they're most vulnerable, and how to identify that in advance of the actual relapse to substance use so that they can then engage some of the skills that we've been trying to teach them for healthier coping with those types of triggers and situations. And so we not only use, you probably will have heard the terms CBT and relapse prevention being used somewhat interchangeably, and that sort of makes sense because there are two real targets of CBT in terms of different phases of recovery. The first is the more difficult part, well actually they're both kind of difficult, but assisting people to achieve that initial period of abstinence from substances when they do come to us pretty uncomfortable in withdrawal, and there is a lot of temptation both internally and externally to use substances, helping them, giving them the support that they need in the education about what to expect in that early phase of recovery to have to overcome. And typically and very often we do this in group settings, which can be very beneficial for substance users to understand that they are not alone in these experiences and the challenges that they need to overcome psychiatrically, psychosocially, physiologically, and in terms of just the sort of automated nature of their behavior patterns that they have learned in relation to substance use by hearing other people's experiences in this area. And then CBT, and then in the secondary phase is designed to provide skills to help people then sustain abstinence, and that's where it's more often referred to as relapse prevention. I'd like to put the CBT into both their behavioral and cognitive components. The behavioral components in the early stages of CBT treatment, the strategies really emphasize sort of trying to figure out the sort of the behavioral geography of the person's lifestyle in terms of how do they schedule their time. And that may seem like kind of a boring thing to talk about in therapy, but and it can be somewhat of a tedious thing. But I will spend a lot of time with his substance users going through a schedule that literally outlines hour for hour of their day. What time do you get up? What do you do when you first to get up. If we were talking about a smoker, you know, what time do you light up your first cigarette, although the talk is a bit more geared to other substance use. But you eat breakfast, you spend time with your children, and really trying to identify where are the times of the day that the person is vulnerable to use substances, and whether that's because there are times of days when they just don't have anything scheduled, when they're really bored, or are there certain times of day when they're alone and have more opportunity to use. And so by figuring out kind of how they're spending all of their time, then we can identify those windows and then work with them to sort of fill those windows with things that are not compatible with substance use. And so the other behavioral concept, which has its cognitive components as well, is helping the individuals to recognize high-risk situations. And a high-risk situation is really anything that increases the likelihood that the person is going to use under a certain condition. And where this can become very behavioral in nature is that we try to help them to figure out some kind of substitute behaviors. What I've found clinically in my experience is that in the earlier phases of abstinence, for the person is more acutely uncomfortable physiologically in withdrawal, it's often easier to engage some type of behavioral strategy to avoid drug use than a cognitive one. So the cognitive ones are more about, okay, I'm thinking about using, but let me think about all the negative consequences. What happened the last time I used, sort of, you know, what in some settings is referred to sort of playing the tape all the way through. I use and then what happens, and then what happens. Okay, I feel really good, but then afterwards, my spouse is upset with me, I miss work, you know, I have to make up for that. So sometimes it's harder when a person's so uncomfortable to engage in that type of process psychologically. It's easier for them to figure out things they can do. They can make a phone call, they can walk around the block, they can attend the club-step meeting. We figure out sort of a repertoire of things that they're able to do just to get out of that state or that situation and really distract themselves until the urge to use passes. And then facilitating positive coping skills such as those I've just described. In terms of the cognitive concepts, really psychoeducation regarding addiction is a very important aspect of it because people like to be able to label things to understand. And so if they can say to themselves, oh, I'm having an urge because I feel this way physically and I feel this way psychologically, or I'm in a triggering situation, or I'm in a high-risk situation, or I'm conditioned to go through this sequence of behaviors that lead me to use because I've repeated it so many times that it's become somewhat automatized, and my brain is telling me to use, and I use the sort of higher order part of my brain, the frontal area, which I'm trying to sort of retrain in abstinence to make better choices. When they're able to sort of label those experiences based on how we educate them about the biobehavioral basis of their addiction, it makes it a little bit easier for them to sort of reach into their newer repertoire of behaviors and try to select an alternative. We also, as I mentioned, see clients about triggers and cravings, and there are different types of triggers, which I have some slides on, triggers related to the environment and triggers that are more internal, like emotions that make them more vulnerable to relapse. So we try, again, to help them to become really the expert on what drives their drug use, because for everybody, there is something a little bit different. Some people are more vulnerable to use when they're feeling really good and they just want to feel even better than good, just like they don't want it to end. And some people are more likely to use when they're having more negative emotions like anger or depression or anxiety. So we try to help them figure out what it is that really drives their use. And a lot of the time they really don't know until they spend a lot of time thinking about it in treatment and hearing what other people are saying and starting to relate to certain concepts. And then we teach them cognitive skills that we refer to as example urge surfing or thought stopping. Thought stopping is literally what it sounds like. It's like a really unhealthy thought about drug use content that is sort of like justifying the idea of using, and they're finding a bunch of reasons why it's going to be okay. And they literally will picture a stop sign and try and have develop an internal mechanism of telling themselves stop. That's an unhealthy thought. That's a risky way of thinking. I need to move on to something else, either doing something else or thinking something else. Urge surfing is based on the idea that we sort of talk to patients about their drug use cravings as sort of taking the form of a wave, that it comes up, it peaks, it gets very intense, but if you are able to wait it out, if you're able to postpone the decision to use, even just say to yourself, I'm not going to decide right now, I'm going to wait 15 minutes, the craving is likely going to pass and diminish in intensity. So they can observe it, rate it, and say, okay, I'm experiencing a craving that I would rate as like a 9 in intensity, and then try to check themselves and do something else and come back to it in 15 minutes or so and say, okay, yeah, I'd say it's down to maybe a 3, and I can deal with it. So we just kind of teach them to ride it out or surf it and as though it was a wave. Red flag thoughts is kind of, as I've been discussing and referring to, anything that increases the likelihood that they're going to relapse. Drug users have all kinds of things and scripts mapped out that they can say to themselves that justify a relapse. In other contexts, this is referred to as relapse justification. Nobody has to know. I'm just going to drink a little bit. It's going to help me relax. Oh, it's going to facilitate socializing a little bit better. I'll start all over again tomorrow, or I'll make up for it somehow. So we teach them to recognize these thoughts and sort of break down the irrational nature of them. Like the idea that nobody's going to know, did that actually matter in their recovery? If nobody finds out this time, if it's actually going to trigger more drug use behaviors, eventually someone's going to find out. But sort of breaking down the irrational nature of some of the thoughts that are sort of designed to trip them up. We've talked about triggers just in terms of knowing which ones, internal and external. But triggers that are external can include people, places, and things, environments where they used to use. Triggers can stimulate all kinds of thoughts of and cravings for substance use. In terms of cravings, so that you know that people experience cravings in different ways. For some people, it's primarily somatic, and we help them to sort of join with that and be able to identify when it's happening. Does your heart race? What is the craving really feel like? It's more towards the idea of becoming sort of an expert on their own condition, knowing that a craving is about to happen or starting to happen before it gets so intense that they actually use over it. For other people, craving is more cognitive, and they have more thoughts in their head about needing to use. This is a list of some of the coping strategies that we teach for dealing with cravings, and I've discussed most of them. So this is just a little summary of behavioral and cognitive strategies in CBT, helping people to analyze a chain of events that result in a slip or a lapse. And optimally, we would also use this with a style consistent with motivational interviewing, which I don't really have time to go over too much today. So I'm just going to go through contingency management because I only have a few minutes left, and I do want to get to the mindfulness data. Contingency management is an interesting one because it's referred to as, in some contexts, as peeing for pay. It's not very much it's not really a psychotherapy. It literally is the enforcement of drug-free urine samples using rewards that are not compatible with drug use. So we don't like to give them money for it because we don't want them to go out and spend money on drugs, but we give them vouchers for items that are, again, going to help them with sort of healthy living, things that they need depending on the nature of the population. But it's the idea that the contingency between a behavior and the outcome is what's really important in shaping behavior or changing behavior, and that the learning occurs best when the behavior is immediately followed by consequence. So if we're going to reward someone for a clean urine, we're going to analyze it on the spot while we're there. We're going to say, congratulations, great job, and we're going to give them the reward right on the spot. I'm not going to spend too much time on this because I'm sort of running out of time. But just to have you kind of aware of this strategy for the treatment of drug abuse, it has been used to treat a number of different types of drug abuse, and has proven effective for treating pretty much every type of substance use disorder to which it's been applied. It is one of the most effective treatments for cocaine abuse, and a recent analysis did show that contingency management does result in successful treatment episodes 61% of the time versus other treatments at 39%. So it is a very powerful strategy. But it does not have that skills component to help people after they're done with treatment to deal with an using situation, because obviously they're not going to be given a prize for not using for the rest of their lives. So it's one of our behavioral treatments in our repertoire. So I'm going to actually skip over this next one, which the main model is sort of an example of a CBT type framework that has been tailored for stimulant users with positive outcomes compared to treatment as usual. But I'm going to skip over and start talking a little bit about mindfulness-based relapse prevention in the couple of minutes that I have left. So we did a clinical trial of mindfulness-based relapse prevention for stimulant-dependent adults. And just to give you a little bit of a flavor of what mindfulness is, it's too much time to describe it in detail. But the way mindfulness has been defined is an approach, a meditation-based approach that cultivates awareness of a person's moment-to-moment experience in a non-judgmental way. So what does that actually mean? Well, mindfulness has to do with really trying to tune into what you're experiencing in the here and now. So if you imagine, what you're doing later, probably we're thinking about things you have to do today, maybe starting to think a little bit about what the weekend was going to be like for you, the things that you have to finish by the end of the workday today, or thinking about the conference. But more than likely, you weren't really thinking about what it felt like to have your foot on the gas pedal, what it felt like to have your hands gripping the steering wheel, paying attention to your breathing from moment to moment and how you're feeling internally. Most of us are just too busy to really sit and think mindfully about everything that we're doing. But this is what mindfulness is intended to train us to do, is to really sort of stay in the present and not be judgmental, and that's important for substance users when it comes to coping with craving, which is a very important target of mindfulness, is that we don't want them to judge themselves for having a craving, try to push it out of their head, tell themselves that they should be doing something else, or that that's bad or it's bad for their recovery. We want them to tune into it, sort of accept it, and explore it with sort of an open curiosity, recognizing that it doesn't need to drive their behavior. That's sort of my snapshot of what mindfulness is intended to do. What we expected it to do with stimulant users is to improve affect regulation, because up until very